This is Brent of the Brookbush Institute, and in this video we're going to go over manipulations or high velocity thrust techniques. I assume that if you're watching this video, you're watching it for educational purposes and that you are a licensed professional with high velocity thrust or manipulation techniques in your scope of practice. If you're not sure, check with your state board. Most physical therapists, chiropractors, and osteopaths, you're in the clear. I believe that ATCs, you can't do manipulations in the United States, although other countries. Again, check your scope. Of course, massage therapists and personal trainers, these are generally not within your scope. Of course, you could continue to watch these videos just for educational purposes, learn a little anatomy, learn a little biomechanics. If you're going to do these techniques, please make sure that you have a good rationale for putting your hands on a patient. This should be based on assessment, and if you're going to assess, I'm hoping that you'll assess, use these interventions, and reassess to ensure that you're getting the result that you're looking for and have good reason to continue using this technique. In this video, we're going to go over talonavicular and cuneonavicular manipulation. I'm going to have my friend Yvette come out. She's going to help me demonstrate. Now we're going to assume that Yvette came in and we've already done our assessment. So if I'm doing manipulations, I'm not just basing them off of passive accessory motion, which a lot of people use as indicators for manipulation techniques. Unfortunately, research points to palpation being our least reliable assessment. Now, I'm not saying don't use palpation, but also maybe have an overhead squat assessment, some sort of postural or transitional movement assessment in there. And then maybe I would follow up with something like goniometry that I can use as my continuous interval measure so that I can reassess and figure out how much progress I'm getting. And then last, I rely on my passive accessory motion and just my palpation skills. So let's say you had feet turn out, knees bow in, some flat feetness on her overhead squat. And then I did goniometry and her dorsiflexion was limited. And that all seems to match her symptomology because she's been complaining about some pretty classic plantar fasciitis symptoms. Right, so I'm going to come over here and I'm going to go, okay, last thing I want to do, last assessment I'm going to do before I do this technique is I need to be able to palpate and do passive accessory motion exam on these joints. Well, to find my talus, I'm going to wrap my index finger and my thumb right underneath her malleoli. And this bone right here that I'm on, providing, especially if I stay up on the anterior portion here, I'm actually on the talar neck. Right? So not only am I on my talus, but I'm on my talar neck, which is going to help because that's the portion of my talus that if I go a little further, right? So you guys here, it's just underneath the medial malleoli. If I go a little further towards the plantar surface of her foot and a little anterior, there's this bump right here. That's the navicular bone, right? That's actually the navicular tubercle. It's a landmark that we can use to help our palpation skills. So now I know where her talus is and I know where her navicular joint is. Now I just need to figure out how I'm gonna do a passive accessory motion exam on those two bones coming together, which is actually pretty easy. I'm just gonna kind of grab the talus like this. I'm going to use a pincer grip around the navicular bone. All right, so if I found my navicular tubercle there, I just have to go above and below it and grab some bone. And then I'm just going to wiggle kind of in this anterior posterior direction. Or I guess technically that's dorsal to plantar direction. Whichever one you want to call it is fine. Right, and I feel a little bit of motion there. She's not particularly stiff at her talonavicular joint. Now I could also check her cuneonavicular joints. I might as well while I'm here. The technique for manipping those joints is exactly the same. My hand position is just a little different. Right, so all I'm going to do is now slide this hand where my other hand was for my navicular, and then I'm just going to slide my hand down a little bit, and you guys will feel like a bump right where the cuneiform joints start. But basically you can slide down as much as you need just to feel like the next thing that wiggles. Right, so the next two bones that you can wiggle in opposite directions. Of course, if I went any further, I'd be on my metatarsal, my first metatarsal, and my medial cuneiform. Of course, if you want to have fun with your anatomy and palpation skills, you can try to feel your middle cuneiform and your lateral cuneiform, right? And you kind of get used to all the joints in there. Now, I know where my joints are. Now, in this particular case, I don't feel a whole lot of stiffness at the talonavicular joint. I feel like there might be a little bit more stiffness at her navicular cuneiform joints. So how am I going to manipulate this joint? Well, there's two techniques I'm going to show you. And keep in mind, guys, I'm showing you this technique so you can see my body position and Yvette's body position. And then we'll do a close-up recap so you can see my hands close up. I'm going to go ahead and use this hand to do my manipulation. I'm going to use this hand to stabilize her foot. And I'm going to use the table to stabilize her talus by kind of compressing her calcaneus and talus together on the table. You guys kind of got what I'm saying? So we're going to stabilize either end and put either the talus or the cuneiform right in between what we're stabilizing, and then apply our dorsal to plantar or anterior to posterior force, however you want to look at it, with a nice high velocity thrust. All right, so we got that much. Now, the key to all manipulations, and this does not get talked about enough, 80, maybe 90% of manipulation techniques is finding the lockout position. Right? So if you can get that joint locked all the way to its tightest point so that the very next motion is essentially the motion you're looking for in the manipulation, you know, that thing that maybe would give you an audible or give you the crack or give you the glide that you're looking for, if you can get all the way to locked up, man, it's a lot easier. The lock position for this technique, you're going to use this hand to bend either the cuneiform and metatarsals if you're trying to manipulate the navicular bone, or just the metatarsals if you're trying to manipulate the cuneonavicular joint. You guys with me there? So just based on hand position, I'm either going to wrap this index finger around my cuneiforms or around my metatarsals, and then this hand will go on which bone I'm trying to manipulate. But the motion is the same either way. I'm just going to bend the metatarsals into dorsiflexion and then externally rotate them. All right, so the lock position in this case is to stabilize the bone you're trying to manipulate and then bend the bones below it up and out. All right, so let me show you guys what that looks like. I know that was a lot to take in. We got this stable. I'm going to grab her foot and I'm going to show you guys this one. I'm going to do cuneonavicular joint, and then we'll do the one that she actually needs. All right, so cuneonavicular joint, I found my navicular bone, I found my cuneiform. I'm actually going to wrap my hands around her cuneiform and metatarsals. I'm going to dorsiflex by pulling up with this side of my hand and then using this part of my hand to press down. I'm going to turn against me. That's going to feel a lot easier once you put your pisiform hamate portion of your hand down on the navicular bone. Right? So I'm going to kind of bend and rotate out against the stabilization force of this hand. And then once I'm all locked out and stabilized, I'm going to get right over the top, take a nice deep breath. Although, really guys, breath doesn't change the ability to manipulate somebody. What you're really doing to get somebody to breathe is distracting them a little bit from what you're about to do and trying to get them to relax so they don't guard on you. But, hey Yvette, take a nice deep breath. And that's it, right? So while she's breathing, I don't even care if she's breathing in or breathing out. That's when I'm gonna do my high velocity thrust. And if you guys noticed, it was a good couple centimeters of motion. The mistake everybody makes, besides not really spending the time on setup, really spending the time on lockout, is their thrust is usually high speed, because people know like it's supposed to be high speed, but then they do this thing, they go, huh, and you're like, I don't think you actually moved your hands. It's not supposed to be the 1 millimeter punch, right? Like, you're not supposed to like get that little motion. Yes, it is low amplitude, but low amplitude still means you have a good couple of centimeters to go. Because think about it, guys, you still have to get through all of the tissue slack. You still probably have to get through some softness on the table itself. Let's talk practically here. You're gonna have to move a little bit to get this thing to actually move. Now, I showed you guys the talonavicular joint. How would I do the navicular cuneiform joints? Or maybe even a little bit of the metatarsal cuneiform joints? I just move my hand down, right? So if I was pisiform hamate on the navicular, now I can go ahead and palpate again. There's my cuneiform right there. I'm gonna go ahead and put my hand down on my cuneiform. I'm gonna grab her metatarsal. I'm gonna go ahead and lock out. Nice deep breath. whap. That's it, right? And you're done. Now, this is one technique. I think it's a good technique to start with. It definitely is much more similar to the way we would like do a joint mobilization for this, which is why I tend to teach it first, is because people are often a little bit more familiar with this body position. But I'll show you the one I really like. It tends to work a little bit better for me, is a longitudinal distraction manip for this. Now, big contraindication you have to think about here. If there is any structural issue that you could make worse with a high velocity thrust, for example, ligament damage, right? Or we have some sort of irritable labral issue, or maybe we have even some low back stuff and we don't want to tug on somebody, this is not the right technique. Go back to the technique I just showed. Now, if that's not the issue, and we have somebody more like a vet who's just complaining about some very classic plantar fasciitis type stuff, this, like this, works really, really well. It's pretty much the same technique, although instead of the pisiform hamate on the top of the navicular bone, what you're going to do is wrap your pinkies around the navicular or the cuneiform bones, depending on which ones you want to manipulate. And then you're going to use your thenar eminence and thumb to dorsiflex and externally rotate the metatarsals. And then your manip, deep breath, it's just like that. Right? A lot of people get exactly like a vet. They're like, oh. But you guys notice I moved like a good 2 or 3 centimeters. It was just nice and quick, right? I spent a lot of time on setup. And I think that's the key to take away from this. So if I was going to go back and do like hernivicular cuneiform joint, don't think I'm going to be like, hey, watch this. Bah! Right? Like that's not, the goal is not speed. It's not the fastest gun in the, it's like the fastest gun in the West syndrome is what we should start calling that. Take all the time you need to set up. If I need to come back here and palpate, your patients don't know. Your patients don't know what you're supposed to do and what you're not supposed to do. So I know her cuneiform is right there now. All right, so I'm going to try to do this a little higher on her foot. Can you back your butt up a little bit so I don't pull you off the table? There we go. Good. Have her take a nice deep breath. Good. Make sure I'm locked out. And I give that nice quick pull. But notice all of the time was spent on palpate, lockout. I'm comfortable. I'm ready to go. Now, boom. Right? That little last part, the part that everybody focuses on, the high velocity thrust, is just the icing on the cake. Stay tuned for the close-up recap. All right, for your close-up recap, guys, here's your first ray. And of course, what we're trying to manipulate is that joint between your talus and your navicular, or your navicular and your cuneiforms. And of course, all of those joints have the capacity to get stiff. And the manipulation technique is the same. It's just going to be a change in hand position. So you guys can palpate the talus by going just under the malleoli, and this navicular tubercle right here, which is just inferior and a little bit more anterior, the malleoli, is a good landmark to get used to find your navicular bone, right? So there's the navicular tubercle. Now I can grab either side. I can kind of see, okay, does this joint move a little bit, right? Does it feel stiff to me, right? Do those passive accessory motions. And then I can go down a little further and go, okay, well, what about the navicular and the first cuneiform? And a vet here actually feels like she's moving pretty good at the first navicular and cuneiform. She doesn't feel like she's moving very good between her navicular and her talus. So if that were the case, I would then want to make sure that I'm trying to move the navicular from a dorsal to a plantar direction during my manip. Make sure that when I place this hand, my pisiform hamate or some portion of the hypothenar eminence is down over the top of it like so. So now I got to figure out how to put this joint in lock position. And the way to do that is you're going to grab the first ray, in this case all the way up to just underneath the navicular with this finger. You're going to pull up into dorsiflexion, right? So you're going to pull the first ray into dorsiflexion at the transverse tarsal joint. So not this type of dorsiflexion, this type of dorsiflexion, as if we're trying to bend the foot this way. And then once I've done the dorsiflexion part, I also want to do a little turning out this way. Right? That'll get that joint to completely locked out position. So now when I thrust, the only place for this joint to go is past its resistance barrier. Right? So dorsiflex, locked out. I got my force right over the top of my navicular. Take a deep breath of it. And as she breathes out, I'm just gonna, and there we go. We got a nice little cavitation there. I know you guys can't hear that, but I definitely felt it. Of course, there is another way to do this manipulation. Right, we can go kind of like a longitudinal distraction technique, although it still is just a plantar to dorsal force on the navicular. The difference this time is I'm going to use my pinkies over the top of the bone I'm trying to manip, whether it's my navicular or my cuneiforms. I'm going to put both hands like this. I'm going to pull into a little bit of dorsiflexion to get her back to neutral at the ankle, but then I'm going to do the same lockout position of transverse tarsal dorsiflexion. So you notice like I moved my hands this way to again bend her foot here. Right? Bend her foot there. Then turn this out. Turn the first ray out, not foot into inversion rather, but turn the first ray out, pull up all the tissue slack, and then nice deep breath, and a little pull. Right, and that's it. That's it. So guys, again, please spend as much time as you need palpating, understanding how this joint feels, stabilizing the bones you need to stabilize, getting your hands in good position, and of course getting those lockout positions so that the thrust is just the icing on the cake. A couple of points to recap. Knowing your anatomy and knowing your biomechanics will certainly help you choose the right technique for the right patient. If you're unsure whether manipulations are appropriate due to their higher intensity, it's okay to do mobilizations. Most research points to manipulations being slightly more effective, but mobilizations being very effective. And of course, we have those videos for you if you want to start with those less intense techniques. Make sure that if you are doing any technique that is based on assessment, and of course that you're reassessing, ensuring that the technique is effective for the patient that you're working on. And when it comes to all manual techniques, guys, manipulations, maybe more than any other, look for opportunities to get live education. Although I know videos are convenient and I'm happy to have these up for you guys to watch, it would be so much more helpful to use those videos as a recap of one-on-one attention with somebody who's experienced with manipulation techniques. At the very least, grab a colleague, grab a friend, and start practicing these before you bring them into clinic and start using them on patients and clients. I hope you enjoyed this video. If you have any questions, please leave them in the comments box below.